Welcome everyone. Last chapter we asked whether people choose their own health, and we saw that seven of the top nine causes of death come down to behavior. Today, in this chapter, we go deeper and ask the obvious follow up. If behavior matters so much, what actually shapes that behavior? So, how psychological factors affect health behavior? Again, so if behavior matters so much, what actually shape that behavior? The answer, as you will see, is rarely just willpower. It's the social world people live in. Let's start with the key terms that will organize our discussion. Here are seven terms to keep in your back pocket today. Number one, the ecological model. Number two, the health belief model. Number three, self efficacy. Social support. Number four, socioeconomic status. Number five. Number six, stress. And number seven is trans-theoretical model. Three of these are theories of behavior, and the rest are factors that influence health. Don't memorize definition yet, each will land naturally as we go. Let's begin with the central ideas of the whole chapter, that behavior doesn't happen in vacuum. Behavior and social environment. Yes, individual behavior matters enormously for health. But there is the crucial qualifier. Many things influence that behavior. Humans are deeply social creatures, and our behavior is strongly shaped by our social environment. And that single fact help explain something epidemiologists have long noticed. Diseases don't fall randomly. They follow patterns across the population. Let me show you what that means. Here's the striking part. Certain groups carry characteristic disease. Certain groups carry characteristic disease pattern that stay remarkably stable over time, even as the individuals in the group are replaced. The people change, but the pattern persists. That tells us the pattern is coming from the environment, not just the individuals. And it leads to powerful strategic insight. It may be far more efficient to change the social environment that pushes the people toward unhealthy behavior than to fix people one at a time. But there is a second, more ethical reason to think this way. The problem of blaming the individual. When we focus only on the individual, we almost inevitably end up blaming the person for their own illness. They should have eaten better, exercised more, just said no. But unhealthy behaviors are often maintained and reinforced by social forces that are genuinely beyond the individual control. So, public health interventions should target those social factors, or at the very least take them seriously when designing programs. With that framing set, let's look at the specific factor that reliably predict health, starting with demographics. Three demographic factors show up again and again: race, gender, and marital status. Again, three demographic factors: race, gender, and marital status. The statistics most in United States, because there is ethnic there. Ethnic minorities have higher mortality from most diseases than whites. Males have higher mortality at every age, though. Interestingly, females suffer more chronic illness, and married people are generally healthier than unmarried, whether single, separated, widowed, or divorced. And there is the key point. Researchers believe these differences are primarily social in origin, not biological. But of all the predictors, one towers above the rest. So, socioeconomic status, the top predictor. Socioeconomic status is the single most important predictor on health. Socioeconomic status bundles together income, education, occupational status. Three things that tend to travel together. And socioeconomic status partly explain those race, sex, and marital differences we just saw. But notice I said partly. I doesn't explain everything, and the race data make the vividly clear. Lowest socioeconomic status, highest mortality, a historical pattern. The group with low socioeconomic status have the highest mortality. And this is not modern American quirk. It holds across many countries and across centuries for reasons both known and unknown. A vivid historical example: in London, 1665, during the plague, the poor died at higher rates, partly from poor nutrition and sanitation, but also because, unlike the wealthy, they simply couldn't free the city to escape infections. The mechanism have changed, but the pattern has not. Let's see how poverty threatens health today. In the modern United States, the poor face a stuck deck. Adverse environmental conditions lead in paint and tap water, air pollution, violence, poor nutrition, less access to medical care, and more psychological stress. Notice how these are mostly environmental and structural, not personal failing. But here is where the story gets genuinely surprising because it's not only about poverty. A gradient across the whole socioeconomic status scale. This is one of the most important ideas in the chapter. The health socioeconomic status relationship is not just poor people get sick. It is a gradient that runs across the entire scale. The very rich and healthier than merely rich, who are healthier than the middle class, all the way down. The classic demonstration is the Whitehall study of British civil servants, which tracked mortality over 10 years across 4 employment grades: top administrators, professionals, executive, clerical staff, and unskilled laborers. The finding: the higher your employment grade, the lower your risk of dying. Let me show you just a gradient. Here's the picture from the original Lancet paper of the study. Read it from the bottom line up. Okay, we will start with administrator. Administrator or administrative, the top grade, the highest, have the lowest accumulative probability of death. Then the professional and executive sit higher than administrative. Clerical staff higher still. And the others category, the unskilled laborers, has the highest mortality of all. And critically, these are steps, a clean staircase. Every step down the hierarchy adds risk. Remember, these are all employed government workers, not the destitute. So what's driving this gradient? Part of answer is behavior. Why higher socioeconomic status means higher, healthier behavior? One big reason: higher socioeconomic status people are healthier, simply that more educated people behave in healthier way. The Whitehall data in the previous study confirmed it directly. The higher employment grade were less likely to smoke, more likely to exercise, and more likely to eat well, with whole grain and fresh produce. Let me give you the hard numbers from the United States. In 2017, 30% of Americans with high school education or less smoked, but only 7% of those with at least bachelor degree did. That's more than fourfold gap. And the more educated were also more physically active. Education is not just a credential, it tracks with whole cluster of healthier choices. Unequal across of medical care has often been blamed for socioeconomic status health differences. And it's reasonable uh, it, it's reasonable suspicion. In 2017, 12.8% of United States adults lacked health insurance, and they were mostly low socioeconomic status group. So, natural conclusion follow: give everyone universal coverage, and you erase the inequalities. It is compelling argument. There is just one problem: the evidence doesn't support it. But inequalities persist under universal coverage. This is the crucial side. Socioeconomic mortalities differences appear just as clearly in Britain, Scandinavian, and other nations with national health program. And the Whitehall study is the clincher. Every one of those civil servants had identical National Health Service coverages, yet mortality was still higher at the lower grade, even after accounting for behavior. So, access to care matters, but it's not the deep cause. Something else is driving this gradient. Now, let's put numbers to these disparities. Even as overall United States health has improved, the racial and ethnic gaps have stubbornly persisted. In 2017, life expectancy at birth was 78.8 years for whites versus 75.3 for black. About 3.5 years gap. And look the infant mortality, nearly double for black compared to whites, and 1.5 times higher for Americans, Indians, and Alaska Natives. Infant mortality is the one of the most sensitive indicators of society's health. So those numbers should give us pause. The disease-specific data are even more dramatic. Look at this table. Walk through these with me. Diabetes mortality is 27% higher for black and 49% higher for American Indians compared to whites. This black men die from prostate cancer at 2.2 times the rate of white men. And the HIV AIDS numbers are staggering. Black men die roughly 16 times the rate of white men, and black women at sorry, the black men die at roughly 6 times the rate of white men, and the women die 16 times the rate of white women. Hold into that HIV disparity. It becomes important when we discuss the prevention. So, what explain all this? Part of its socioeconomic status. Socioeconomic roots of disparities. A good portion traces a good portion traces back to the lower socioeconomic status of black Americans. The black median household income is over 21,000 US dollar below the United States average. More than 20% of black lived in the poverty in 2017, and this is a new data, versus 8.1% of non-Hispanic whites. On average, black have less education and higher unemployment. But, and you will recognize this theme, socioeconomic status doesn't close the gap entirely. The complexity and the public health mandate. The honest truth is that the reasons of these socioeconomic disparities are complex and somewhat resistant to public health interventions. And the socioeconomic status health link still is not fully understood. But not understanding something completely doesn't excuse us from acting. Public health must still find ways to improve the health of groups and have been disadvantaged economically, educationally, and politically. And that work starts with understanding which factor drive health behavior. So let's open up the black box and look at one of the most powerful, the stress. Stress psychological factor influence health, and they may be part of why socioeconomic matters so much. The first is stress, which flows from the adverse physical and social condition of lower socioeconomic status. And stress harms health through two pathways: directly by altering psychological process, and indirectly by changing behavior. Think stress eating or stress smoking. Where did the evidence for stress's lethal effect first come from? A poignant source. A poignant source. This is the evidence for stress lethal first come. The earliest clues came from widows and widowers who had unusually high risk of dying soon after losing a spouse. Studies in the 1960s and 70s found survivors' mortality was 40 to 50% higher in the 6 months after spouse's death compared to married people of the same age. Researchers then expanded this to the other stressful events: death of the other family member, divorce, job loss, and found all them raised the risk of illness and death. The broken heart turns out to be more than a metaphor. Now, let's look at the particularly elegant study linking stress to heart disease. Stress and heart disease, the bank study. This is a beautiful natural experiment. Two banks, two banks with employee groups that started out similar. Then one bank went commercial. Its workers now faced fierce competition, financial risk, and the heavy responsibility of investing fund. The other, the semi-public saving bank, stayed low pressure. Over 10 years, the commercial bank employees had 50% higher rates of heart attack and sudden death. Same people, more stress, far more cardiac death. But how does stress actually get under the skin? For that, we turn the immune system. Stress and the immune system. The animal study now. The animal studies from rats all the way up to baboons show that psychological stress lower immune response and increase atherosclerosis. But the human evidence is what I find most compelling. Researchers measured stress in 420 healthy volunteers, then literally dripped cold viruses into their noses, keeping a small control group. The higher stress subjects were more likely to get infected and more likely to actually develop cold with all the classic symptoms. So, stress doesn't just feel bad, it measurably weakens your defenses. This finding helped launch an entire new field, psychoneuroimmunology. That field is psychoneuroimmunology, a mouthful, but break it down. Psychoneuroimmunology. It studies how the mind and nervous system interact with the immune system. Now it's clear. It's our best hope of explaining at a mechanistic level how things like stress and, as we'll see, social support translate into physical health. Now, here is the link back to socioeconomic status. Low socioeconomic status people simply experience more stress. Why lower socioeconomic status means more stress? And it is not only major catastrophes, it's the daily hassles that pile up lower on the socioeconomic status ladder. The car that breaks down, the landlord on your back about later rent, the unreliable child care, the rude official. For minorities, add the constant background of uh, uh, racial prejudice. The insight here is profound. These small chronic stresses may be just as debilitating as death in the family. Meanwhile, higher income, higher income and education act as buffer against life hassles, protecting health, which bring us to the things that help people cope, coping resources. And this is the final slide in this part. What helps people withstand stress? Money. Obviously, solve a multitude of problems. Education provides the information and the problem solving skills to navigate difficulties. And family and friends offer both emotional support, a shoulder to cry on, and instrumental support, a ride to the doctor, a meal. That last one, social support, turns out to be far more important to health than anyone expected. In the next lecture, I will show you the landmark study that proved it. Thank you for your attention and see you again later. Goodbye.